Next, we have a long case presentation by Dr. Adarsh and Dr. Shabari on the topic MS in pregnancy. The internal examiner will be Dr. Shanthi, Professor of Government Medical College, Kottayam, and the external examiner will be Dr. Ramkumar Venkateswaran, Chief Medical Officer of Mission Smile, former HOD of KMC Manipal.
Hello. Well, good afternoon to everybody. And I must thank the organizers, all my friends on the organizing committee for having given Dr. Shanthi and me this opportunity. And I'm forgetting your names. Into the mic.
Shabari
and
others.
Okay, so the four of us are indeed thankful for having provided this platform to discuss the mitral stenosis in pregnancy. Okay, so what we're going to do is not going to too much. We have two problems on hand, okay? Mitral stenosis and pregnancy. Not that pregnancy is a problem, but it's difficult when both these occur together. So we won't go too much into medical details. We'll cover only the essential medical details, okay? So we can present a case, okay? It's more important to discuss the anesthetic implications, all right?
So ours is a 23-year-old female, gravida 3, parity 2, living 0, and intrauterine death 2. She was admitted to local hospital for safe confinement on 17 March 2025 at 37 plus weeks gestation. And persistent high heart rate was observed, and echo revealed valvular heart disease and was referred to Medical College Kottayam. She was apparently normal till 8 months of gestation when she developed breathlessness, which was more on lying down and is relieved on sitting upright. She also had history of severe breathlessness at 9 months of gestation while asleep. It was relieved by sitting upright and gradually resolved over few minutes. There is no history of any generalized fatigue or chest pain or palpitation, syncope, pedal edema, pain in the right upper quadrant of abdomen. There is no history of any facial puffiness, hoarseness of voice, or difficulty in swallowing. And there is no history of any chronic cough or respiratory tract infections. And no history of swelling, headache, or blurring of vision. And there was no history of any dyspnea on exertion. She was able to climb more than 2 flights of stairs in the pre-pregnant state. And there was no history of any prior cardiac events or interventions, and no history of any other comorbidities. And she had IUDs on 2 occasions at 7th month and 9th month of gestation in 2020 and 2022. And it was not associated with any breathlessness or palpitations or syncope or hemoptysis in those pregnancies. Coming to the present pregnancy, first trimester was uneventful.
Okay, I know you have all the details. Just sum up what is essential. Otherwise, keep going, okay?
Yes, sir. First trimester was uneventful. She was started on tab enoxaparin and injection enoxaparin in view of 2 IUDs in the past.
Okay.
And second trimester was uneventful. And in third trimester, she had history of breathlessness on lying down at 32 weeks of gestation. It was relieved on sitting upright. It was not associated with any cough or hemoptysis or syncope, and no medical attention was sought for the same. And she also had a history of breathlessness while she was sleeping, for which she had to suddenly wake up, and it gradually relieved on sitting upright at 36 weeks gestation. And she was admitted to a local hospital at 37 plus weeks gestation for safe confinement, and high heart rate was detected and was evaluated and revealed valvular heart disease, and she was referred to Medical College Kottayam. And on drug history, she was on iron, calcium, and folic acid, and as already mentioned, she was on enoxaparin and injection enoxaparin. It was stopped at 12 weeks gestation from the local hospital itself. And on admission to Kottayam, she was started on tab metoprolol 25 mg BD and injection, tab Lasix 20 mg BD. And family history, her sister died at 24 years when she was 20 weeks pregnant and was diagnosed to have heart disease during pregnancy.
On general examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Pre-pregnancy weight was 61 kg and present weight is 71 kg. Height is 153 cm and
essential, only essential important features.
Okay, the heart rate was 160 per minute, regular, normal in volume and character. BP was normal, JVP was found to be elevated. Airway and obstetric examination was essentially normal. And on cardiovascular inspection, on inspection, apical impulse is not seen, no significant findings. And on a palpation, apex beat confirmed at the fifth left intercostal space in midclavicular line, and it was typing in nature. Thrill in apical area felt in left lateral position during expiration, and also left parasternal heave was present. And on auscultation, loud S1 was followed by S2 in the mitral area, and also there was a low-pitched rough rumbling mid-diastolic murmur of grade 4 intensity with a presystolic accentuation over the apex in the left lateral position was heard. Also, a loud P2 heard in the pulmonary area. Respiratory system and central nervous system was essentially normal. Coming to the final diagnosis, 23-year-old lady, gravida 3, parity 2, living 0, intrauterine death 2 at 37 weeks plus gestation, single live intrauterine gestation with a cephalic presentation, complicated by rheumatic heart disease, severe mitral stenosis with severe pulmonary arterial hypertension in sinus rhythm in failure.
Okay. Good. Okay. Both to Sabari and others. Normally in an examination, you get about 30 minutes for a long case. All right. And you get about 5 minutes to present your case, which you've done reasonably well. Okay. Can you summarize what are the important things that you're going to be addressing when you manage this patient for anesthesia? What worries you about this patient? Sabari?
So the goals in the anesthetic management include to prevent any tachycardia, to maintain adequate preload, to maintain adequate afterload, to maintain the myocardial contractility, and to avoid any factors which cause an increase in pulmonary vascular resistance. That is, we have to avoid any hypoxia, hypercarbia, acidosis, or even hypothermia.
Okay. So essentially, you're trying to look at all the factors in the heart that you want to normalize. Okay. Right. From the history of her pregnancy, does anything worry you?
Yes, because in pregnancy, the cardiovascular changes in pregnancy, such as...
Right, you hit the nail on the head, okay, Adarsh? I don't want all the changes that happen in pregnancy. In relation to a patient with a heart disease, okay, I want you to summarize the cardiorespiratory changes in the patient, in a pregnant patient that will affect valvular heart disease, any valvular heart disease.
Cardiovascular changes, mainly the increase in intravascular volume up to 35 to 45%, and there is an increase in heart.
I don't want the percentages, I know you know it, okay? Just tell me what are the things that you are worrying about. So there is a change in blood volume, okay? Anything else that worries you?
An increase in heart rate,
okay?
And also increase cardiac output,
right?
Stroke volume,
okay.
And a decrease in systemic vascular resistance.
Okay.
These are the cardiovascular changes in pregnancy.
Okay. Have you heard of anemia occurring during pregnancy?
Yes,
is that good in a heart patient?
Yes.
Is that good in a patient with a heart disease, anemia?
Yes, sir.
Anemia, what will it further do to the heart rate?
In anemia, because the circulation will be hyperdynamic, and more cardiac output will be the demand, and because this is a mitral stenosis already fixed cardiac output state, the demand anemia will further worsen the patient. Two things
in the history. Okay, she's had 2 pregnancies which she lost 2 children at 7th and 9th month. We do not know the reason. Possibly not due to heart disease. Maybe she was not symptomatic at that time. That's what you said. And she's lost a sister. So maybe there's a family history of something running in the family. Fine. So now this patient has come to us at 37 weeks of gestation, all right, with a history of rheumatic heart disease, right? And you rightly said, what are the factors, the changes that happen in pregnancy that's going to be of importance? Did either of you mention a change in rhythm? Is that important? Rate and rhythm should go together. Okay, when you talk about, so any heart disease, okay, you think of looking at it as changes in preload, how will it affect, changes in afterload, how will it affect, changes in rate and rhythm. Okay, so these are the things that you have to normalize during your anesthetic management. Okay, now let's go on to the anesthetic management straight away. Okay, we have about 30 minutes left now. Okay, so how are you going to investigate this patient? What investigation do you think are mandatory before you take, and before that, Dr. Shanthi, would you like to ask anything about the pre-operative history, and then we'll go on to investigations, okay? Wait, madam is going to ask you anything that she wants to ask you? You're smiling, this is like match fixing, is it? No. Okay.
Oh,
no
what
issues.
about the pre-operative
No, they are very well prepared.
investigations?
They've been talking to me for the last 2 months, okay?
What do you think the mode of delivery like?
In this patient had NYHA class 4 symptoms. On further evaluation, her mitral valve area was found to be less than 1 centimeter square. Okay. So a patient with NYHA class 3 and 4 symptoms with a mitral valve area of less than 1.5 centimeter square, with presence of moderate to severe mitral stenosis, or if the patient is in atrial fibrillation, general anesthesia will be the preferred mode of anesthesia, and cesarean delivery will be the preferred mode of delivery in such patients. As
Okay,
these
so
patients
now you're straight away going to the mode of delivery. So I've got some other questions, okay, which will come on. So she's come at term, you're saying general anesthesia will be the technique of choice if, you can repeat that for my benefit.
if the patient is having a functional class of NVHF 3 or 4,
Okay.
with a mitral valve area less than 1.5 centimeter square,
Okay.
with the presence of moderate to severe pulmonary artery hypertension, or if the patient is having atrial fibrillation.
Okay, suppose the mitral valve area is 2.5 square centimeters and she was asymptomatic till the 8th month, then she started getting a little breathless. Okay, and NYHA classification is now in NYHA 2. Would your plan change?
Yes, sir. In such patients,
Let's give it to Adarsh. What would you do in your changed history now?
If the NVHA classification is 2 and valve area is greater than about 2.5 centimeters square, the patient can be managed, undergo normal vaginal delivery provided that proper neuraxial analgesia is given to the patient to control the changes during
So
labor.
I'm going to pose 3 situations to you. Okay. One is you're going to allow the obstetrician and anesthetist decide to give the lady a chance of vaginal delivery, in which case you will still have to give good pain relief. Point number 1. Second, the patient is going to be subjected to a cesarean delivery. Your patient, others, okay, not the one who's NYHA 4, okay, NYHA 2 patient, is going to now come for a cesarean delivery, and the obstetrician informs you 3 days in advance. Okay. And the last one is the patient actually comes as an emergency for a cesarean delivery. Okay, Adarsh will tell us first about the first situation.
The patient, cesarean delivery.
Sir?
Is it cesarean delivery, sir?
No, vaginal
First
delivery.
patient, vagina.
Vaginal delivery,
In
obstetrician wants your help.
Okay.
Why do you have to give good pain relief? And
Because
why does a patient with mitral stenosis in pregnancy, why does she worsen
Because
during labor and delivery?
during normal labor, the pain associated with the labor increases the heart rate, and sympathetic stimulation associated with the labor
Agreed.
and catecholamine release during labor increases the systemic vascular resistance, and
Agreed.
increase in heart rate compromises the diastolic filling time, and it causes the preload. Left atrial pressures to increase, and further complications leading to pulmonary edema. And also the pain during labor causes hyperventilation. This hyperventilation can cause hypocapnia, and this hypocapnia can lead to fetal hypoxia because of the shift of oxygen
So
dissociation.
you both brought in a very important point. All patients with heart disease need not undergo delivery under anesthesia. That's the point you brought forth. Okay. How are you going to help this patient and the obstetrician to have as less pain as possible during a normal vaginal delivery? What can you do?
We can provide epidural analgesia for the patient
Okay.
to control the pain. A lumbar epidural can be obtained for this patient, and infusions of 0.125 to 0.065 of bupivacaine can be administered as infusion to the patient to control the pain.
Okay. So that is if she's already in labor, or as an
In
elective
labor.
procedure? She's already in labor. Can you give anything intrathecal when they're already in labor and she's having pain? Already
Opioid administrations.
Okay. Do you practice labor analgesia in your hospital?
Yes, sir.
You do. Have you been part of a team that does labor analgesia?
Not much, sir.
Not much. Okay. Not much means how many cases have you done?
Rarely, 1 or 2. Yes.
Don't be scared, okay? It is the obstetrician who's preventing us from giving labor analgesia, not the anesthetist, okay? So don't worry about it, okay? So fine, so you have seen 1 or 2, so you know what we are talking about, right? So do you prefer an intrathecal injection of an opioid to a labor epidural analgesia full-fledged if she is in acute pain? She's already in labor, she is in active labor. The baby has started descending, okay, station 0. What will you give at that time? I'm not going to teach you obstetrics, okay? Though my wife is an obstetrician. Station 0? That means has labor started?
Yes.
No. So will a labor epidural really work at this point? What do you think? Sabari, yeah.
Sir, whenever we...
He'll help you out. You both are doing the case
yeah.
together, both on duty together, okay?
So whenever we are administering or we are giving epidural analgesia, it should be given in a slow and titrated manner over 15 to 20 minutes.
I'm not giving you that time, dear. That's why I'm saying patients already in labor.
So
So,
in such cases, we will avoid any epidural and
right. I think
intrathecal
it's a good
opioid
idea
can
when the patient's already in active labor. Go for something that will act immediately. And if you are in the practice of giving a intrathecal opioid, that's the best. Okay.
Intrathecal.
Now let's say the obstetrician says, I want to induce, I want this patient to be delivered vaginally 3 days from now. Can Sabari and Adarsh come and provide labor analgesia? Then you can consider epidural. Okay. Now is this patient on any, likely to be on any anticoagulants?
Sir, she was started on enoxaparin.
So we had a beautiful lecture by Manjit. I don't think we need to go into that. Okay. So what kind of anticoagulant was this patient on?
She was on low molecular weight heparin,
Okay.
but the indication was because she had a history of 2 intrauterine death in the past. So considering a bad obstetric history, she was started on enoxaparin and niclosamide.
Okay. So what do you want to do with that? If you're considering a labor epidural, what is your
Sir, we will follow the ASRA guidelines to put an neuraxial catheter. For low molecular weight heparin, low dose low molecular heparin, ASRA recommends a minimum gap of 12 hours before putting up a...
So I've given you 3 days, no? That's why I gave you 3
Sir,
days.
we have adequate time to stop the anticoagulants and prepare the patient for neuraxial anesthesia.
Okay.
Sorry, analgesia.
Right. So in that period, what's going to happen? Now you stop. How many days? When are you going to stop it? 12 hours before you said.
For low dose, we can wait for 12 hours.
Okay. Do you think combined spinal epidural has any advantage in a situation where you're given a 3 days advance notice?
A combined spinal epidural, the initial administration of an intrathecal opioid will provide a better quality analgesia, early and quality analgesia. So we can sequential combined spinal where we give...
Suppose I'm a first year PG posted with you. I say, why don't you give some, bupivacaine intrathecally? It'll act nicely. You're considering, any one of you, yeah? I don't know the answer, so I'm asking you as a first year PG. I have not seen intrathecal opioids being given. The first year is saying, why are you giving opioid? Why can't I give bupivacaine?
Intrathecal opioid, intrathecal local anesthetic will cause sudden sympathetic blockade and can cause sudden profound hypotension, which can worsen the patient if the patient is having mitral stenosis and fixed cardiac output state. Okay. So we have to avoid that complication. So we will mostly prefer intrathecal opioid, which has got good analgesic property, but the sympathetic blockade is avoided in this patient.
The reflex tachycardia is also detrimental in the patient.
Okay.
Due to the decrease
so,
in ACR.
I think essentially you would think of it this way, okay? A subarachnoid local anesthetic is going to bring on the analgesia much faster. However, it's got a drawback of associated hypotension and possibly bradycardia also. You can't control it that way. Whereas a labor epidural, you can control it. So there are 2 different situations. One already in labor, you dealt with the second situation, 3 days advance notice given by the obstetrician. Now, unfortunately, she's brought in with an emergency cesarean section. Okay, category 1 cesarean section, and you've been called. You're on duty. You go see the patient. You evaluated the patient as you already told. Okay, what's your plan now?
It depends upon the kind of emergency. Like if there is any fetal distress or where we don't have much time to position the patient and put the epidural, and even if you are putting the epidural.
Non-reassuring fetal status. Mother is relatively stable.
Okay, in such cases, if the patient is having mild to moderate disease, we can definitely go for a graded epidural, where slow and titrated dose of epidural will be given over a period of 15 to 20 minutes to obtain the adequate level of, like in case of the first stage of labor is associated with pain from T10 to L1, so adequate level till T10 will be obtained, and in second stage there will be more of a somatic pain from S2 to S4.
Well, it might be
Question
1 minute.
was cesarean.
Dr. Shanthi wants to say something, yeah, please.
No, sir was asking cesarean.
What, madam?
Sir was asking cesarean.
Cesarean section, category 1. Okay. You know the categories for cesarean section?
Sorry, sir.
So it's a...
So we have to achieve a level of
T4
T4 to
section. You can't wait for time. Okay. So there's a non-reassuring fetal status. Okay.
In such cases,
You have any other answer to that, Adesh? He wants to go for an epidural. Would you like to disagree or you agree with him?
If the fetal distress non-assuring fetus is, we will likely to go general anesthesia, sir.
I would also accept his answer, okay? Right? So let's now plan together how you're going to do a general anesthetic for this patient, okay? What monitoring would you like to have?
Along with the standard,
Now, what was the original thing you said? 1 square centimeter, was it? 1.5. We'll go back to your patient only. 1.5 square centimeters. NYHA class?
4.
4. So that's the kind of patient you're taking up for a cesarean delivery, okay? The fetus is non-reassuring. Go ahead. So no question of intrathecal or epidural, okay?
along with the standard ASA monitoring such as heart rate, BP.
Are we in America? Anybody? Who's in America here? Look, Balabhaskar, over lunch we were talking about monitoring standards. I didn't tell you that, but 99% of the answers they talk about standard ASA monitoring. What is standard ASA monitoring? Where are we practicing? In Wayanad? Or wherever you know, Kottayam? Do you use standard ASA monitoring there or do you have Indian guidelines for it? Start thinking Indian, okay? Dr. Balabhaskar is working very hard towards that, okay? So, what is your now standard ASA practice? Tell me. What is your standard ASA practice? Let's see this. What is standard ASA practices? Come.
Sir,
I hate the standard ASA practice. I'm not an examiner anymore, except at ISA Midcon. Okay, so you're all safe. Okay, if you say AHA, I will send you off to America, and Trump won't accept you.
sir,
Okay.
we will follow the Indian standard. Like
What is the Indian standard? Come over here and shake hands with me. Yeah. Okay. come, seriously. Okay, now tell me what is the Indian standard. Okay.
Sir, we'll attach the monitors like pulse, the ECG.
What would you do in your hospital in Kottayam?
Yeah, sir, we will, for monitoring, we will use heart rate monitoring using ECG.
From ECG.
ECG.
3 electrode or 5 electrode?
5 electrodes, sir,
Very
5
good.
lead,
Next.
5 lead ECG.
Is it important in this patient?
Yes,
You
sir,
have
it
to have
is,
5
sir.
electrode? Okay,
This
done.
patient.
So 5 electrode, so that is one.
ECG. Then
Which is
pulse
also common to
oximetry.
AHA. Okay, then
Pulse oximetry.
pulse oximetry. We have here, that also AHA also has that.
So non-invasive BP monitoring.
Okay, we have that.
Yes, sir. And in this case, as this patient comes under NYHA class 4 with severe symptom, like it comes under severe mitral stenosis, we will also consider putting up an invasive blood pressure monitoring.
Excellent. Do you do it in our hospital?
Yes.
Would you do it if this patient comes?
Yes, sir,
Okay,
because
then.
it is of utmost important.
Agreed. I agree. So, but the first 4 monitors have agreed.
Yes,
okay.
sir. And,
5 lead ECG, pulse oximeter, NIBP plus.
Plus,
arterial
we'll also
line.
consider
Fine.
putting up a central venous catheter monitoring.
Okay.
Because he helps in, first of all, it helps in providing the inotropic support, and also it will help us to guide the fluid therapy, and it is also.
Don't fully agree. We'll leave it for the end. Okay. Don't fully agree. Okay.
So, okay, sir.
No. CVP monitor may not be really useful in mitral stenosis.
Okay,
We'll
sir.
come to that point later. What else?
And also we will consider the fetal monitoring if there is any.
Fetal monitoring, yes. Cesarean delivery, I'm sure the OBG registrar will be monitoring the fetal heart till we prepare the patient for for GA. Okay, next.
So these are the monitoring parameters.
Post-induction, anything is there?
Yeah, we will also we will also do a transthoracic echocardiography to assess the volume status.
Excellent. Do you have that in your hospital?
Yes, sir. We have a access to transthoracic echo. We have the.
Fine. Okay, in this case, you will definitely do it if you have it.
Yes.
Okay, then. Would you use a simple urinary catheter? Important.
What? Yes,
Urinary
a urinary
catheter is
catheter to monitor the urine output.
Right.
Yes, sir.
Okay, urinary catheter is also important. Then, would you like to use a capnograph? Will it help in any way?
Yes, sir. It is here.
Do you have all of this in Kottayam?
Yes, sir.
Then why go to America?
Sir, just forgot, sir. Sorry.
Don't go to America. Okay. Right. We have everything in India. Think Indian in future. Anything else anybody wants to add? Why this controversy? I'm not happy with CVP. Anybody in the audience can stand up and answer, but don't waste time. Time is. Raise your hand. We'll give you the mic. PG, not staff. Any PG? Okay. No answer. Right. Why? Let's finish it off now. Why is a central venous pressure reflects pressure in which chamber?
Right atrium and right.
Okay, now this patient has got
Sir, this patient had
severe pulmonary arterial hypertension.
hypertension and secondary right ventricular.
And we know why that has happened, right?
Yes, sir.
We know that the normal process of mitral stenosis, as you follow the progress of the disease, eventually they'll end up in severe pulmonary hypertension. And therefore, that's not going to really reflect your right. You want a left-sided pressures if you want at all. It won't, because it's already gone through the process of left-sided pressures going up, pulmonary hypertension happening. There'll be structural changes in the pulmonary arterial system, and that will have a back effect on this. So it's not going to help.
Okay, sir.
If at all you want to guide fluid status, maybe a PA catheter will help.
Okay, sir.
Okay, but it's plus minus for both, right? You have an echo, fine.
Yes, sir.
You have an echo, you have a transesophageal echo, you said, right? TE.
Yes, sir.
If you have that, well and good. Okay, but even a transthoracic maybe will help. I'm not
Yes,
too.
we have transthoracic, but we
Also,
don't
right?
have it trans.
So you can
esophageal.
actually see the heart filling, is it filling, underfilling, overfilling, all of that can be made out there. All right. So you have that monitor, you can use it. Fine. Okay, now let's rewind the clock. Okay. Let's say cesarean well managed, both of you. Okay, at different stages of labor. All right. Now let's say the patient was in the first trimester of pregnancy, and unfortunately she deteriorated. The obstetrician sent for a cardiac consult. The cardiologist says this patient will not go through pregnancy unless she has a balloon valvuloplasty. Have you do such procedures in the cath lab in your hospital?
Yes, sir.
You stood by for something like that?
No.
Not yet. Okay. Right. But you must have read about it.
Yes.
You know what I'm talking about?
Yes.
Mercury.
So she's probably just in her about maybe, a 10th week of pregnancy, and she has deteriorated. Her cardiac status has deteriorated. And they want to improve the forward flow through the left atrium. And their cardiologist says only chance for this patient is a balloon valvuloplasty. How will you manage this patient in the cath lab?
Percutaneous balloon mitral valvuloplasty can be done under IV sedation or general anesthesia. In this patient, since the patient is already in failure, there is high chance of cardiac arrest and decompensation. So we will prefer, it is always we will prefer general anesthesia, because by general anesthesia we have an adequate control of the airway, and also it has the additional benefit of doing a transesophageal echocardiography during the intraoperative
It won't be
period.
uncomfortable for the patient, you're saying, right? Okay, excellent answer. Anything to add, Adarsh?
Also, the better hemodynamic control will be achieved, can be achieved during general anesthesia.
Not really. Once you interfere, better hemodynamic control is something that is imaginary, okay? You just have an endotracheal tube inside. You can control breathing, but you can't control the hemodynamics. Don't believe that, okay? But I think your answer was spot on. You said that you can do it under local anesthesia or LA infiltration, but a general anesthetic will give you more control if the patient is on the verge of going into pulmonary edema or something like that. It will give you better control over the respiration, not really over the hemodynamics. Okay, so that is, and what will be the problem? Are there any problems to the future pregnancy of this patient? Continuation of pregnancy, if you give a general anesthetic, full-fledged general anesthetic in this patient in the first trimester of pregnancy?
Because the drugs used during general anesthesia can cause fetal hypoxia, fetal bradycardia, and fetal loss can be also occur.
Okay.
So it is riskier if we for the fetus if you go for general anesthesia at that time.
Correct. Okay. What about teratogeny? What's the teratogenic period normally? What is this period of teratogeny that we're
Up to
talking
12
about?
weeks, the organogenesis occur in the first 12 weeks of pregnancy.
So that's why I very critically said 10 weeks to put you into a trap. Okay. So right. So that means whatever anesthetic agents you're using, if you're forced to use it, can have a potential to affect the growth of the fetus also. Right. So this must be explicitly told to the mother and to the husband that we are doing this for saving the mother. You might have a problem with the baby. Unless you explain yourself out, the child is born with some anomaly, you are in trouble later, especially in Kerala, right? Okay. I may escape in Karnataka, but Kerala, I don't think you can escape. So explain everything to your patient. Tell them that we are doing this to save the mother. However, there's a possibility of a teratogenic effect on the baby. So if there is a chance, okay, let's say the mother is doing fairly well, you discuss with the obstetrician, okay? The cardiologist says that you have to do the mitral valvotomy first before the delivery. She certainly cannot go through the intense activity during labor. Shall we just finish that off? What happens during labor that can be a problem for a patient with rheumatic heart disease, mitral stenosis? What are the things that can happen that can complicate mitral
Because
stenosis
all stages
during labor and postpartum period?
all stages of labor, that is first, second, and third stage of labor, is associated with the increased cardiac output and pain associated with the labor cause sympathetic stimulation and increased systemic vascular resistance, hyperventilation, hypocapnia.
Okay, fine.
So we have to this increased cardiac output and intravascular volume during the first, second, and third stage of labor will cause increased preload to the left atrium and can further complicate the existing pulmonary arterial hypertension or right ventricular failure, and patient can go into decompensation.
So because of all this, we'll constantly watch for any evidence of pulmonary edema. Okay, and since you have a transesophageal echo, it's also going to tell you how the heart is functioning throughout your anesthetic. Okay, anything else? One, you're right. Yep, last 10 minutes, thank you. Yeah, you can help, Sauri. What are we discussing? We're all lost, huh?
Third stage of labor.
You thought the bell means over, we can leave, huh?
After the third stage, after the delivery of the baby.
Okay, I'll put the
Second
question
stage
slightly differently, okay? Sabari, the cardiologist, the obstetrician and the anesthesiologist have discussed the case, and they say this patient will not go up to term, okay? Need not be operated in the first trimester, okay, but can be done in the second trimester. Would you be happy with that?
Yes, sir.
Why?
Because by the end of second trimester, already the organogenesis will be completed.
Very good.
And chance of embryopathy will be less.
Okay.
And also by 20 weeks, around 20 weeks, the uterus size will be comparatively smaller, and there can be adequate shielding while the procedure, and the fluoro time can also be reduced. Yes, so we'll prefer in the late second trimester, ideally around the 20 weeks, and it is associated with better outcomes.
Suppose the mother and father discuss and they say, no, it's even inappropriate time for us. We can only do it in the 8th month. What problems additional problems can happen?
Percutaneous balloon mitral valvuloplasty done in the third trimester is associated with better maternal outcomes, but it has a slightly increased risk of preterm delivery or preterm labor.
Okay, so are there any drugs available that the obstetrician can use to delay or slow down uterine action? Tomorrow I'm talking about oxytocics. Now you can tell us about antioxytocics, okay, there is such a term. Do they use anything to prevent premature labor? Okay, tell me over tea, okay, right? Let's go on now, right? Now suppose they say that the mother is really at risk and there is no opening snap. So this valve is not conducive to do a balloon valvuloplasty. Okay, so we have to do an open mitral valvotomy, not a valve replacement, but an open mitral valvotomy. Right? Have you given anesthesia for that?
No, sir.
You don't do. Okay. Do you have cardiac in your theatre, madam?
Not our, it's a separate block.
Okay, madam will ask you questions.
So, open mitral valvotomy, that is done under cardiopulmonary bypass, no?
Yes, sir.
So that is an open heart procedure. So what are the risks?
CPB is associated with the non-pulsatile perfusion. So there is increased chance of decreased uteroplacental blood flow and can lead to fetal death.
Cardiac anesthetists in the audience will help me out. They switched mostly to pulsatile flow now, right? Do we still have non-pulsatile pumps happening? I don't do any cardiac, now or before I retired. I think most centers have switched over to pulsatile flow.
It is CABG only, sir.
Not CABG.
Only for CABG, no? For
Not
valve
CABG.
and all, non-pulsatile only.
Non-pulsatile, okay. Correct me, I am wrong. Okay, madam has corrected me. Go ahead, okay.
Because
So non-pulsatile flow, what will happen to the fetus?
Decreased blood flow to the fetus.
Okay.
and fetal loss can occur.
Okay.
And since it is an open heart surgery, there is increased hemodynamic changes, increased blood loss associated with it. And also there is an increased chance of infection, prolonged hospital stay, increased chance of thromboembolic events.
Okay.
So it is associated with an increased risk factor.
Fine. There is something that I forgot. I just want to bring that back again. Okay. So in that, I think one of you said that in when the lady goes into labor, there's a lot more stress on the heart. Okay, she's bearing down, and there is a increased blood coming back into the system after the baby is delivered, right? So that auto transfusion can also be a problem because the lady cannot stand any kind of extra blood volume. So you have to be very judicious about IV fluids also, which is the reason why we considered CVP slash pulmonary capillary, PCWP catheter. Okay, right. Now what? Shanthi, you want to ask anything? While my mind thinks of anything else. We still have 5 minutes more.
So what is your post-operative plan if it is a cesarean?
Intense monitoring of the patient in the post-operative ICU is very important.
Excellent, thank you. Yeah, very good.
As these patients are more prone to develop, there is an increased chance of maternal mortality and morbidity in the immediate postpartum period. So intense monitoring for at least 48 to 72 hours in the ICU is very important. So we'll ensure adequate oxygenation in the post-operative period, propped up position, use of beta blockers to control the heart rate, use of diuretics to reduce the LA pressure, judicious fluid management guided by transthoracic like focus ultrasound if at all present,
okay.
And adequate analgesia in the postoperative period will optimize the patient.
Okay, so actually the general anesthetic we stopped just with monitoring, no? AHA monitoring we gave and we stopped. How are we going to induce this patient? We never induced this patient finally, did we, Venugopal? We didn't, I think, no? Tell us now, we still have time. How are you going to induce that patient in that last scenario that I gave you? For a cesarean delivery, category 1 status, stat, cesarean delivery.
Sir, we'll use modified rapid sequence injection,
Okay.
Using fentanyl, etomidate, and muscle relaxant rocuronium will be of the choice.
Okay.
Fentanyl will be given at a dose of 2 to 4 microgram per kilogram. At the same time, we will alert the pediatrician to be ready with the naloxone. And etomidate, titrated dose of etomidate to obtain the adequate depth of anesthesia. To reduce the stress associated with laryngoscopy and intubation, we will use lignocaine at a dose of 1.5 mg per kg IV or beta blocker.
Sorry, I missed your fentanyl dose. How much was it?
Yes, sir.
What is the fentanyl dose you gave?
Sir, 2 to 4 microgram per kilogram.
2 to 4 micrograms.
So
Is that normal?
No, sir,
or for obstetrics you give that much?
No, sir, we usually give 1 to 2 microgram per kilogram, but this...
For obstetrics you give more, is it?
No, sir, in this case, this is a case of severe mitral stenosis and sudden falling hemodynamics and SVR should be avoided.
Okay.
So it's always better to go with an opioid, slightly increased dose of opioid during the induction so that we can reduce the IV induction agents like it.
Okay, got it. Despite using etomidate?
Yes.
Okay, fine.
Along with...
Okay.
Okay, and we can also use beta blockers like esmolol to reduce the laryngoscopy stress, and the muscle relaxant for intubation will be rocuronium at a dose of 1 mg per kg IV. And
is it your practice, madam, you've done away with succinylcholine, or does anybody still use succinylcholine for cesarean delivery?
No, we
Anybody uses succinylcholine? Please raise your hand.
We
Nicely,
use,
I use.
we
If
use,
I were to,
yes, sir, we also use.
we also use.
then why are you talking about rocuronium? AHA, yeah?
No, sir.
Tell what you do when you're not doing wrong.
The electrolytes are normal.
Sir, if the electrolytes are within normal limits, we can
You could have asked
definitely
me,
go for...
are electrolytes normal? I would have told you.
Yes.
Why should the electrolyte be abnormal? This patient is on diuretic and probably getting potassium supplements as well, right? The cardiologist would have taken care of that.
So we'll,
Okay.
muscle relaxant, we will use succinylcholine.
Succinylcholine, I think, is still the standard. I would vote for that. Okay,
Yes, sir.
in India, definitely. Rocuronium is the reason why it's not really, I would say, not really the ideal choice. You don't get as good a relaxation as succinylcholine, and you want good relaxation here. All right, unless you are thinking it's going to be a difficult airway. You said airway is normal, you had said in one of your slides. Suppose this is a patient with rheumatic heart disease, 3rd trimester of pregnancy, has gone into failure and is also having a difficult airway, then maybe if you have Sugammadex, you all use Sugammadex?
Yes.
Okay, if you have, you should have a full dose for reversal of the effect of rocuronium. What's the full reversing dose of Sugammadex?
16 mg per kg.
Right, unless you have that, no half-hearted attempts. Don't say I'll give only 4 milligram per kg, but I will use rocuronium. If you put your foot forward and say I'll use rocuronium, you must have 16 milligram per kg of Sugammadex available. Okay, otherwise it's not fair on your part to give rocuronium. Otherwise use succinylcholine. A lot of people have raised their hands. Okay, it's not wrong to use succinylcholine. You still get the best intubating conditions under succinylcholine, and I would vote for that. Nothing wrong with that.
Yes, sir.
Okay, right. Last 1.5 minutes. Any questions from the audience? Sudesh, keltira another. Anything that you want to ask us, Shanthi and me, which may have been unclear or you wanted us to discuss, please ask. You still have only 1 minute left. If it's nothing, we'll set a trend. We'll finish before time. Thank you.
Thank you, sir.
Guru, yeah. Guru sir wants to know, you want to know how they'll manage, sir, or how they diagnose? Okay, so this was that critical patient, you see, who was NYHA class 4, whom we were giving GA, and we did mention that you'll use transesophageal echo, possibly even auscultation, SpO2, all this will tell you whether there's a pulmonary edema developing. Right. Sir wants to know how will you manage pulmonary edema?
So we'll provide 100% oxygenation, propped up position. Then
No, this is cesarean going on. Cesarean going on, okay.
We'll provide 100% oxygenation, provide diuretics like furosemide, and we'll also use an optimal PEEP to reduce the pulmonary congestion. And also we'll find out the cause that has precipitated the pulmonary edema. Like if there is any tachycardia, it will be managed. It can be due to inadequate analgesia or inadequate depth of anesthesia. So such things will be managed. Okay, sir, we will use diuretics to reduce the effect of
it's
autotransfusion.
very common, actually, as soon as the baby is extracted and the uterus contracts. So suddenly 500 to 800 ml of blood will enter back into the circulation, and that will not be tolerated by these mothers with such a severe cardiac disease, especially the mitral stenosis. So they'll go for pulmonary edema. So that is a common time. So as you said, 100% oxygen. Another thing is head-up position, so that you reduce the venous return, and also most of this blood goes down. It doesn't fill up in the chest and then produce pulmonary edema. So that is another thing. Of course, morphine also can be used in this situation, but we don't use, because why morphine is, when you give 100% oxygen, you are cutting off all the other anesthetics many times. Even volatile anesthetic agents, you may have to cut down, because you cannot increase volatile anesthetic agent because they are going to relax the uterus. You are giving very low dose of inhalation anesthetic agents. So morphine definitely will help. So anyway, we are not going to extubate such patients on table. We are going to take her into the ICU and then extubate her leisurely. So that's how. And head-up position is very, very important.
Thank you.
Morphine, head-up position, 100% oxygen as you said, and furosemide. And treat the cause also. Suppose it can be also be because of some dysrhythmias that occur. So that also, as you said, tachycardia is the most common problem.
Thank you, sir.
Just some last 2 pieces of advice. Okay, when anybody in the exam asks you for, hello, if you're asked about monitoring, okay, go in a systematic manner. Either the way you apply it on your patient, okay, which is the first one, which is the second one, and so on, or you divide your monitors as monitoring before induction of anesthesia, monitoring after induction, then you won't forget anything. Okay, and whatever you're practicing, you say. You're using succinylcholine, nothing wrong in saying that. The examiner has an objection, they will ask you why, and they will reason it out. Okay, so succinylcholine still, worldwide, is the first drug for cesarean section. You're not wrong in saying it. Okay, and whatever you do in your college is right. Your teachers will not allow you to do wrong. Say that boldly in the exam. Okay, thank you.
Thank you, sir. Thank you.
Thank you, doctors. Now, I request Dr. Ramkumar sir to distribute participation certificates to Dr. Adarsh and Dr. Shabri. Now, may I request Dr. Gurudat sir to please come onto the stage to felicitate Dr. Ramkumar sir. I also invite Dr. Joan Cheriat to please come onto the stage to felicitate Dr. Shanthi.
On a lighter note, I went to Sikkim for an airway conference. At 3 sessions, they gave me 3 such mementos. I put it in my cabin baggage. They disallowed it. They said this looks like a dagger.
Hello. Check.
And I was not carrying 3 daggers. So I was retained as the security because of that. So no dagger shaped. No more daggers. 3 daggers are there.